It's an immense pleasure to welcome Dr. Brian Kim this morning to give a lecture we've all been itching to hear on chronic pruritus. Sorry, Dr. Kim, had to do it. You probably get that all the time. So he comes to us from Washington University in St. Louis, where he's Associate Professor of Medicine in Dermatology, Anesthesiology, Pathology, and Immunology departments, and is the co-director in the Center for the Study of Itch. He has a really incredible and impressive CV. He received his medical degree at the University of Washington School of Medicine, followed by his dermatology residency, Master of Science in Translational Research, and postdoc at UPenn. He's received too many awards to list. He's an ad hoc editorial reviewer for many journals, including the JID, JAD, New England Journal of Medicine, Science, and others. He is really well known in the field for his clinical and research interests, which focus on itch and the innate immune system. And I know that pruritus is something we all struggle with treating, and dermatologists and definitely our patients can really benefit from his extremely important work. Thank you so much for coming this morning, Dr. Kim.
Thank you, Dr. Mancuso. Thank you for the introduction. Thanks to Dr. DiNardo for actually suggesting me as a speaker, and of course, Dr. Gallo as well. Can you all see my screen okay here?
Yes, we can.
Okay, I'll get right into it. So, thank you all for having me. I enjoyed I was actually watching some of the cases, and it was great presentations, and I learned quite a bit from watching as well. I don't do general dermatology anymore, so the grand rounds is the only time that I get to see a lot of interesting cases outside of my area. But I do focus exclusively on itch, both clinically, as I wouldn't say exclusively scientifically, but we do focus on it considerably. And that's what I'll be talking about today. And I want to keep it somewhat casual, so please feel free to chime in along the way. And we'll be presenting today on kind of relatively recently published work to really kind of set the stage and give a background for our recent work that was actually unpublished under review now. And it will be also mostly really centered around atopic dermatitis. Here are my disclosures. We have a number of disclosures related to atopic dermatitis, and fortunately, actually a lot more in the way of companies that are interested in developing therapeutics specifically for itch. So, I actually started, since I'm at a grand rounds presentation, I started focusing on atopic dermatitis clinically as a resident when I was at the University of Pennsylvania. And I actually had a specialty clinic back then. And this is really a disease that we've been very, very focused on. And I wanted to focus on atopic dermatitis because at that time, we all witnessed the kind of revolution in psoriasis with targeted biologic therapies. And that really, to me, was a proof of concept that, and it might sound silly now because this is so obvious, but back then, the idea that you could just block one cytokine or one receptor and have such a profound effect on the disease was a rather fresh idea to me. And seeing what was happening in psoriasis, we decided to really go into atopic dermatitis at that time. So I started clinically. I actually saw children at the Children's Hospital of Philadelphia as well. And I started there, but even before my postdoc, and then went into my postdoctoral lab and decided to focus on immune pathways that we thought would be very important for atopic dermatitis at that time. So it was still somewhat predictive in terms of the biology that we were doing. So at that time, the kind of paradigm of the pathogenesis of atopic dermatitis was as follows: that we have a skin barrier that should be intact. And then also slightly before that time, Erwin McLean's group had made the landmark discovery that mutations in filaggrin result in a leaky skin barrier. And this is one very convincing explanation that the skin barriers are important, and that when you have a leaky barrier, you can actually get translocation of putative inflammatory stimuli or allergens that then somehow, somewhat mysteriously activate this T helper type 2 or Th2 cell that then results in the production of these, what we used to call Th2 cell associated cytokines IL-4, 5, and 13. And then this results in a variety of downstream effector mechanisms, such as production of IgE, which is a major feature of atopy and allergic disorders, as well as activation of mast cells and damage to the skin barrier as a result of these cytokines. During my postdoctoral work, it was revealed that epithelial cells can directly engage the immune system by upregulating cytokines like IL-33 or thymic stromal lymphopoietin or TSLP. And these cytokines are referred to as alarmins, and that when the barrier is stressed or breached, that they can rapidly activate the immune system and polarize towards this Th2 or type 2 inflammatory pathway. But the mechanisms weren't entirely clear at that time as to how this was happening. And what we identified was that previously unrecognized contributions, or entirely not even identified yet, innate cells like group 2 innate lymphoid cells or ILC2s as being major sources of cytokines like IL-5 and 13, as well as circulating rare basophils coming into inflamed tissues to be major sources of IL-4, and really putting the innate immune angle as a major player in the pathogenesis of diseases like atopic dermatitis. But I want to highlight one thing right now is that we know that IgE reactivity is essentially, it's a very confusing topic because IgE reactivity is actually considered in part a defining feature of atopy. So whether you have atopic dermatitis, asthma, food allergy, this reactivity is considered a defining feature, yet we don't know what the role of IgE is in atopic dermatitis, and it's very, very unclear. And I'll come back to this later in the talk. So what we were really focused on initially, as I've just kind of summarized, is understanding how the skin as a barrier surface goes from being healthy to inflamed, and what are the molecular and cellular events that trigger or initiate this process, but also what are the pathways and mechanisms that perpetuate this process. But more recently in our laboratory, we've become interested in understanding how inflammation leads to sensory dysfunction, such as itch. So I just to put everyone on the same page, you know, when we think about the sensory nervous system, there's a couple of interesting points. That for one, we employ what we call the somatosensory nervous system, which are essentially a variety of different nerve fibers that innervate the skin and can sense everything from pressure, touch, friction, temperature, pain, as well as itch. And it's predominantly thought that these non-peptidergic C fibers are the ones that actually sense itch. There's more to come in this regard, but that's the classical understanding. And by non-peptidergic, it means that these nerve fibers generally aren't thought to necessarily release neuropeptides, but rather they just function as electrical signals in a way that go back to the dorsal root ganglia and then synapse into the spinal cord. And then within the spinal cord, there's a whole circuit of neurons, interneurons, that then result in projection neurons going to the brain and the cortex where these sensations are perceived. So itch is really just a subset of the somatosensory nervous system, which senses so many different things. And just a little bit of a commentary. I'm actually a card-carrying immunologist, and one of the things that has always been kind of difficult for me has been that skin biology or skin immunology has often been marginalized in my view in many ways. The fields of gut biology, gut immunology, or even the airway has always been a lot bigger, and it's always felt like we were a little bit on the fringe. But when it comes to what we're going to talk about in the nervous system, the somatosensory nervous system, it's interesting. It really, skin is the organ designed for the somatosensory nervous system. So this incredibly elaborate network that's such a big part of our peripheral nervous system really skin is the organ. It's the main organ for this. So it's a way, in my view, to kind of put skin into the mainstream in a way that's been traditionally somewhat challenging. So how does this work? If you actually hone in on the axon at the tissue that actually innervates the skin. Just broadly, generically, what happens is a neurotransmitter binds a receptor, like a G protein coupled receptor. This then results in the opening of a cation channel, such as TRPV1 or TRPA1, and then this causes a membrane depolarization. And then the depolarization of the membrane, if sufficient, can activate other voltage-gated sodium channels that then, once you exceed a threshold, results in an action potential. And this sets off this cascade to the spinal cord, to the brain, and it works its way up as an electrical signal. The other thing I want to emphasize here is that the brain and the spinal cord and the dorsal root ganglion neurons are really work not just in terms of from signal to signal to signal, but that compartmentally they're very connected. So they're actually all also bathed. A lot of people don't think about this, but they're also bathed in CSF all together. So there's actually an anatomic connection there. So now let's get a little bit into the function. So how does this work? I gave you a generic template for how this works, but let's bring this back to something we can all relate to, which is, in my view, is histamine. So histamine was one of the first molecules identified to be able to elicit itch. And how does histamine do this? It binds one of its receptors, at least H1R. It binds a receptor, it activates TRPV1. TRPV1 is what actually is activated by capsaicin, which we're familiar with. And then we get an action potential. This comprises about 15 to 30% of the sensory nervous system, or the dorsal root ganglia. And this was kind of, has been used as a paradigm or model of understanding how factors derived from the immune system, like mast cells, in the context of histamine, can actually activate the nervous system. But also, one problem with histamine has been that it has not been a great target for chronic itch. Actually, the vast majority of chronic itch disorders are not responsive to antihistamine therapies. There are select cases, particularly acute itch in the context of urticaria, in which antihistamines can be effective. So in that regard, clinically, the histamine pathway has been somewhat disappointing. But with the discovery of other factors like IL-31, which is actually a cytokine, this actually brought us kind of new insight into how we can probe other pathways that might actually be important. And IL-31 is thought to be a cytokine that's actually originally described as being predominantly produced by those adaptive Th2 cells that I talked about in the very beginning. And what was really interesting about IL-31 is that it was shown very quickly that it actually induces itch, and in more recent years has been shown to act like a neurotransmitter by binding its receptor on the sensory neurons with somewhat variable dependence on TRPA1 and TRPV1 cation channels, and then thereby presumably can activate an action potential even on a small, only about 5% of the DRG network, and evoke itch sensation. So, and this is clinically important to us because it's looking like anti-IL-31 receptor antibody treatment will likely be approved first, looks like in Japan. They just reported phase 3 clinical trials recently in the New England Journal. And so this is an emerging strategy, and particularly an anti-itch strategy in atopic dermatitis. So taking a note from this paradigm, we asked in recent years, and understanding that these innate cells are major sources of these classical type 2 cytokines, could there be an interaction now between these cytokines and the receptors on sensory neurons? And this was work that was done by MSTP student Landon Etchen from my laboratory, who is actually now a neurology resident at Mass General. I tried to get him to go into dermatology, but he got too interested in the nervous system from this work, I think. So it didn't happen, but that's okay. So what we did was we actually just looked into DRG. So can the sensory nervous system actually, does it actually express the components to respond to these type 2 cytokines? And in fact, we detected expression of IL-4 receptor alpha from mouse dorsal root ganglia, as well as native IL-13 receptor alpha 1. Shown here, we could never detect the IL-5 receptor, and we could as you would expect, detect the IL-31 receptor. This is conserved. If we actually take DRG from cadaveric human donors, we find that this is largely conserved between mouse and humans, this expression pattern. So then we wanted to test whether not only do these neurons express these receptors, but can they actually functionally respond to these cytokines? And the way in which we do this, we actually label DRG neurons with a dye called FUR2. And then we can test, and the way this dye works is it can actually detect calcium that comes into the neuron. And then if it detects calcium, it turns red. And so we can actually read out these red signals as these spikes. And what we find is that when we spike in recombinant IL-4 into mouse DRG in vitro, we see a nice spike. And we can confirm that these are neurons by showing that they actually respond to potassium chloride. And we see a similar kind of response for human DRG neurons with IL-4, as well as, and then we can confirm that these are actually TRPV1 positive because they also respond to capsaicin. So, so that in humans, obviously, we can't really test in a very specific compartmental way. How does a drug like dupilumab, for instance, work? We have to go into mice. And we have a mouse model in which we actually can topically apply the irritant MC903 or calcipotriol onto just regular old wild type or any kind of mice, topically onto the skin. We do use the ear skin, and we can very reproducibly and reliably induce atopic dermatitis-like disease. This model has been well established and shown to provoke a number of immunologic axes that are well associated with atopic dermatitis, as well as the skin lesions. If we, in our hands, actually now perform RNA sequencing of the lesional skin in these mice, what we find is that these mice actually exhibit a transcriptional signature that mirrors what's been largely reported cumulatively in human atopic dermatitis skin. But importantly for us, over time on the x-axis and then scratching bouts on the y-axis, what we find is that these mice develop chronic spontaneous itch over time in response to the development of AD-like disease. And so what we did was we actually took a genetic approach to really test now that these cytokine receptors are expressed in the sensory nervous system, if we delete them specifically just in the sensory nervous system and nowhere else, because they're ubiquitous expressed, can we actually shut down itch and have any effect on the disease? And in fact, if we actually look at scratching bouts over time in mice that have been conditionally deleted of the IL-4 receptor alpha, just on peripheral sensory neurons only, what we find is that we see a significant reduction in itch, as well as a reduction in terms of skin thickness as measured by ear skin thickness. And histopathologically, we see a reduction in the inflammatory infiltrate as well. So, and since this work is published, in the interest of time, I won't get into details, but what we teased out was that in large part, it's not so much that these type 2 cytokines are great inducers of itch, but rather their kind of tonic signaling or even slightly elevated signaling in sensory neurons can actually promote their hyperreactivity to a variety of other itch-inducing factors, or what we refer to as pruritogens. So we think that this is at least in part one mechanism by which drugs like dupilumab may work. At the time, we were also broadly interested in not just type 2 cytokines, but how cytokines in general can actually operate in the nervous system to potentially mediate itch. And we know that dozens of cytokines act through their cognate receptors, but they use a shared downstream intracellular signaling pathway through the JAK-STAT signaling pathway. And this was important for us because our thought was, okay, we know that type 2 cytokine pathology is associated with atopic dermatitis, but it may be a lot dirtier than that, and there may be a number of other cytokines that are involved. And we don't have time to do this kind of work every time with each cytokine. Is there a way we can just, for clinical therapy, just jump ahead and try to figure out a way to get at this in patients in a more efficient manner? So we went after the downstream kind of conserved pathways of JAK signaling. And we hypothesized that JAK1 in particular would be really important of the 4 JAKs. And then and we identified that basically by looking in DRG neurons at the single cell level, and identified that JAK1 was the most highly expressed. But here we took a similar approach, and we simply deleted JAK1 in peripheral sensory neurons. We induced AD-like disease. We actually looked earlier to see if we could actually uncouple the effects of JAK on itch from even the effects on tissue inflammation. And what we found was that we could actually demonstrate a very marked and significant reduction in terms of itch in these mice in which JAK1 was deleted in the neurons, even before we see any difference in the disease, difference in disease severity. So what we think is happening is that there's actually a kind of a different way to kind of think about sensory, the sensory paradigm of cytokine signaling. So we know, and we've known for a long time, that in lymphocytes, cytokine receptors like alpha receptor alpha are very important. They employ JAK-STAT signaling to exert their effect on the cell, but that with the identification that with the identification that the nervous system can actually express these receptors and these different components, that perhaps there's a different kind of mechanism of action, so to speak, by which we can understand how itch is propagated or initiated in the setting of tissue inflammation. And it's very important that these cytokines actually engage directly with the sensory nervous system. This has, we think, potentially broad implications. We're kind of delving into kind of new emerging, less well-recognized entities. And this is in part important to us because we have a chronic itch clinic here at WashU, and patients, not with atopic dermatitis, but patients with chronic pruritus of unknown origin or idiopathic pruritus come to us from all over the country to see us, and they don't have good therapeutic options. Even the etiology of their disease is not well understood. And so the idea here is that, is there a way we can kind of jump ahead and get at the itch, even if we haven't completely painstakingly mapped out the pathways? And we think that JAK inhibition may actually be a potential strategy. So we see these patients, they have scratch marks everywhere. They don't really have primary lesions. It's hard for me to imagine how this is actually a primary lesion. These are just scratch marks. And these patients really don't have a clear diagnosis of why they're itching. We call them chronic pruritus of unknown origin. And we've been able to give a number of these patients over time JAK inhibitors off-label for a variety of reasons. These patients actually improve, at least anecdotally, based on these kind of proof of concept observational experiences that we've had with patients. This is in response to the JAK inhibitor tofacitinib orally. Bringing this back to atopic dermatitis, we also are observing in clinical trials, this is with the topical ruxolitinib cream, effects of these drugs that indicate perhaps the biology that we're unveiling, it may actually be operative in patients. So this is a trial that I helped design with Insight Corporation, and they have great phase 3 data now. This is from the phase 2, so this is probably going to be the first topical JAK inhibitor approved for atopic dermatitis here in the next year or two. Just real quickly here, this is a phase 2 multi-center trial with 6 arms from control placebo vehicle to active comparator triamcinolone cream, 0.1%, as well as a range of concentrations of the topical ruxolitinib, anywhere from 0.15% daily to 1.5% twice a day, over 8 weeks, and these patients were then entered into an open label period. If we actually now, the trial was successful and met all primary and secondary endpoints, so I'm not gonna go over that, and it's published now, but what we found was that these patients demonstrated within actually 1 day a significant reduction in itch that continues to improve quite rapidly over time. In the phase 3 data that's available now, the top line data, they actually detect a significant reduction in the itch at the higher doses within 12 hours. So it's quite rapid. It's needless to say, all the biology that I've described up to this point, we all know in dermatology now, this is a very, very active area of pharmaceutical development with these IL-13 antagonists like lebrikizumab, tralokinumab. There are a number of JAK inhibitors in phase 3, if not completed phase 3 trials, including abrocitinib, baricitinib, upadacitinib, delgocitinib for chronic hand eczema. So this is a very kind of explosive area of drug development. And what's been really gratifying for us is to see how the biology that we've kind of probed is able to be predictive of a lot of the clinical trial effects that are detected in either the, typically in these secondary endpoints of itch. So this is where I'm going to actually take a little bit of a turn into our new stuff, and hopefully what I presented will give context to what we're going to talk about here. So what I'd like to propose, and one of the things that I've clinically appreciated in patients is that we've been talking about chronic itch a lot, but in the clinic, patients certainly have chronic itch. They have some level of itch every day, but we also know that they experience acute itch, and that's not something that we measure in clinical trials. It's not something we really talk about. So as an example, patients with atopic dermatitis will have a 5 out of 10 on their NRS itch scale from 0 to 10 score as their chronic itch level. But then they'll call me, I'll see them on Monday, and then they'll call me on Wednesday and say, I'm going crazy. My itch is 10 out of 10 right now. And we know that this happens, and this dynamic shift in itch is something that is very hard to capture. And the biology of this is not well understood either. And that's what we're going to talk about here. So we actually decided to probe this a little bit, and we actually collaborated with Regeneron. And they've run obviously they have a lot of phase 3 clinical trial data from the dupilumab studies. And we actually took a look more deeply at these daily itch scores that they have. So this is kind of high resolution itch data. And we decided, can we see if these patients actually do have just kind of chronic stable itch, or is there a lot of lability in their itch? And so what we found was that, in fact, what we thought is happening. We have certain patients, like patient number 1, who actually experience these kind of acute itch flares. So they go up and down. They might have a good period where they're just at a chronic itch, and then they flare up to a 7, sometimes a 10. And then we have other patients, like patient number 2 in the blue line, that actually never really seem to experience this acute itch flare pattern. So what does this mean? Well, one of the things is, the patient number 1, the problem with patient number 1 in these clinical trial measurements is they actually average out sometimes to just an NRS score of 5. So we think they're the same as the blue line. But as you can see, that this patient may be having much worse days than the patient in the blue line. So then we looked across all of the placebo group patients in the trial, and we said, okay, well, how many of these patients actually exhibit this pattern? And what we found initially over the first month is that 26.4% out of 159 patients exhibit this pattern, while the others do not. So then we thought, is this a stable thing? Does this actually demonstrate a unique subset of patients, or is this actually a broader phenomenon that may actually involve a number of patients, and depending on when we catch them, some may be flaring while others don't. And what we found was that the initial acute itch flare pattern of patients, a lot of them maintained this kind of acute itch flare pattern, shown here in this kind of striped red. But then in the second month, an additional 20% of patients started to develop this acute itch flare pattern within this whole cohort from the trials. A minority of patients, shown here, about 3%, actually lost this acute itch flare pattern. So whatever reason, they spontaneously got better, or they weren't exposed to whatever environmental factor that may be triggering this. So this is where actually it gets back to IgE, as I mentioned. So we thought, what kind of pattern of itch, what could it be that is actually triggering this kind of acute itch pattern? There aren't that many things in immunology that trigger very acute responses. Mast cells do, we know that, and mast cells are coated with IgE. So we thought, could this somehow be related to IgE? And fortunately, Regeneron, in a very insightfully and having a lot of foresight, actually did IgE allergen reactivity repertoire analysis in these patients. What we found is that if we just bin these patients into those who actually have allergen-specific IgE, and then those that do not, at least by these immunocap assays, that there's a significant enrichment for acute itch flares among patients who actually harbor allergen-specific IgE. And the interesting thing is, we've known for a long time that patients with atopic dermatitis, upwards 75%, have allergen-specific IgE. I mentioned this has been known for a long time. IgE reactivity is in part a defining feature of atopy, but we never really know what IgE does in this disease. So then we went back into our mouse model that I described earlier, and we decided, let's model this. And I'm going to try to walk you through this. I have not presented this data very much at all. So this is actually the second time I'm presenting this. So bear with me. But if you just take a naive mouse now, and then you treat it with this irritant that I showed you earlier called MC903, what you can actually do is you can actually take a model allergen like ovalbumin or OVA, and apply it simultaneously to the inflamed skin, that leaky barrier, and you can sensitize these mice to the model allergen ova. Of course, as I've already shown you, when you treat these mice with MC903, they develop chronic spontaneous itch in the lesional skin. But what's interesting is if you do this, you sensitize these mice, but then you just challenge them with a fresh dose of ovalbumin now. You're not sensitizing, but you just challenge them, even in their cheek, in non-lesional skin. These mice actually develop a very robust acute itch flare. Okay, and I'll show you that in a second. Control mice, in contrast, don't develop AD-like disease. So we give them the vehicle ethanol and we give them the model allergen to attempt to sensitize, but they don't get sensitized because their skin's not inflamed. They don't develop chronic spontaneous itch. And of course, as you'd expect, based on what I told you, they don't develop an acute itch flare either. And in fact, if you look in the serum, the control mice don't develop allergen-specific IgE, while the sensitized mice do, as you would expect. So that's not surprising based on what I've told you. But now if we actually look at scratching bouts on the y-axis and then you just look at time on the x-axis, I want to just take you through this very slowly. The control mice, they don't have AD-like disease. Even though we give them topical ova to sensitize them, nothing really happens because they don't have inflammation in the skin. And that's shown here in the circles, the blue circles. And then when we challenge with the ova, you don't get a response. So you see in the red here, the red circles, you don't get a response because the mice are not sensitized and they just go on like there's no problem. And then, but in contrast, when you actually give MC903 and you give atopic dermatitis-like disease, you see a jump here. You see chronic spontaneous itch here. So it's at a higher level. And then when you challenge with the ovalbumin, in the red squares here, you see an acute itch flare bout. And then this is in fact acute because over about 30 minutes it starts to resolve and they go back to their chronic spontaneous itch here. So this is essentially an acute on chronic itch. If you challenge the same kind of mice with irrelevant BSA, so not ova, but BSA protein, what you actually get is that they can't mount a response. And that makes sense because they weren't sensitized to BSA, they were rather sensitized to ovalbumin. So what we are able to do, what we think is in a way model an IgE-mediated itch that is very much associated with this sensitization. And so the mice develop allergen-specific IgE, and that allows them to develop this kind of acute itch flare. So as I told you, in atopic dermatitis in general, in terms of just a chronic disease, the role of IgE is very unclear. The trials have been very confusing. They've gone both ways. And in mice, what we find is that deleting IgE has no effect on the chronic spontaneous itch. So this is the baseline itch. But as you would expect, we see a reduction in the acute itch flares upon challenge when we actually get rid of IgE. So IgE is a critical molecule to bind the allergen to mediate this kind of itch. So we thought, okay, this has to be mast cells. So we've known for a long time that that the role of mast cells is very unclear in terms of the actual itch, direct itch in the chronic spontaneous itch. And in fact, if you take mast cell deficient SASH knockout mice, there's no effect on the chronic spontaneous itch. But what we're really surprised by initially was that it also had no effect on this acute itch flare. So mast cells being the canonical cells that actually bind IgE, what's going on here? Well, we know that mast cells bind IgE by way of the high affinity Fc epsilon receptor. They release things like histamine, not just histamine, but a lot of other factors, and they're largely, almost exclusively tissue resident. But we also know that they're basophils, and I mentioned that in the beginning, and they're actually in circulation, and they very much resemble mast cells in terms of their function. They also release histamine, as well as a number of other factors that are very similar to what mast cells release. And so we thought it must, then maybe perhaps basophils may be actually in the setting of inflammation coming in and taking over. So we actually looked in patients with atopic dermatitis for basophil activation. And the reason to support this idea, it's well known that a variety of cytokines activate basophils. So they essentially prime basophils to become much more sensitive. So cytokines like IL-3, IL-18, IL-33, what they essentially do is they stimulate basophils so that they just become hyperreactive. And one way to measure in a very generic way, whether basophils are activated is to look at their expression of CD203C. And what you find in the dotted line here is that atopic dermatitis patients express more of this surrogate activation marker, and this is statistically significant, as well as a receptor for IgE. If we actually look for the receptor for IgE in these patients with atopic dermatitis, it's upregulated as well, indicating that these basophils are primed and perhaps poised to be much more responsive to IgE stimulation. This is the same in our mouse model. So MC903 mice, we use a different marker in mice called CD200R. We see upregulation in mice, and as well as Fc epsilon receptor as well in the MC903 setting. So we took a step back. So we thought, okay, so basophils may be involved, but actually to date, it has not been shown fundamentally that basophils have any physiologically important role in mediating itch at all. So we thought, well, why don't we just take a kind of proof of concept approach? And to do this, we actually generated mice in which we selectively expressed a designer receptor. And so this is a chemogenetic approach. So we inserted a G protein coupled receptor that is actually responsive to an otherwise inert pharmacologic compound, clozapine. So what this receptor allows is that it actually, if you inject the mouse or treat the mouse with clozapine, and then we express this receptor, this designer receptor, only within basophils by using a basophil specific Cree. What we can do is non-specifically and selectively activate basophils only and see if this has a physiologic effect. So this is really just a kind of acute way to be very technical and to really drive a proof of concept. And if we actually stimulate basophils with CNO in this context, what we find by avidin staining is that we see that they're actually activated and degranulated in vitro, and we see that they just look, it looks like just a degranulated basophil essentially. We see the contents all over the place by avidin staining. But then additionally, what we find importantly for us is that with even just one injection of the CNO and the activation of the receptor, we can induce acute itch bouts in mice, as shown here on the right. So understanding that we can just simply stimulate the basophil and induce itch in mice, we then wanted to go back into the model and test, is there a way to actually delete basophils and then affect this itch? And we fortunately been studying basophils for a long time. We have these Bastrec mice that actually express the diphtheria toxin receptor. Mice are resistant to diphtheria toxin, so we can insert the diphtheria toxin receptor into these mice selectively. And then we challenge them with diphtheria toxin and run them through this acute itch flare model. And what we can then do is deplete basophils very effectively, as shown here. These cells are the basophils right here in the upper right quadrant, and we can get rid of them. And importantly, what we are able to do is actually attenuate the acute itch flare, as shown here on the right. So we thought, what could it be from basophils that's actually meeting this kind of acute itch flare? We know that basophils produce a lot of factors like histamine, serotonin, tryptase, prostaglandins, and leukotrienes. These are all factors that have been known to function as pruritogens in different contexts. Important to note that these are also all produced in various quantities by mast cells as well. But through a screen, we systematically eliminated a lot of these other possibilities, and what we arrived at was actually leukotriene C4, LTC4. And what we found is that mice that are actually treated with ovalbumin to evoke acute itch flares actually have elevated quantities of LTC4 in the serum. And if we deplete basophils in the manner that I just showed you, there's actually a marked reduction in serum LTC4 concentration as well if we eliminate these basophils, strongly suggesting that the major source of these LTC4 is basophils. So how about on the neuron? We're talking about basophils and how these might be effector cells, but how about the nervous system? Well, if you actually take a synthetic LTC4 and actually now stimulate the sensory neurons and perform calcium imaging the way that I described earlier, we can map out which kinds of neurons are actually being activated by this LTC4. And what was actually kind of rather striking to us is that what we find here in the green is that if you look at the neurons that are activated by LTC4, there's essentially 100% overlap with neurons that are actually responsive to capsaicin. So these are TRPV1 cation channel positive neurons, as well as TRPA1. So these are canonical cations that permit depolarization of the membrane. And what we find is that LTC4 really is completely overlapping with this, which it doesn't have to be the case. Some peridotins will reside more in the TRPV1 compartment, others will be on the TRPA1 compartment. And importantly, when we actually look at these neuronal responses, we see that if whether we delete TRPV1 or TRPA1, we can't abrogate this neuronal response. But if we actually do a double deletion, we can actually eliminate this calcium response in the neuron. So if we eliminate both TRPV1 and TRPA1, we can make this the sensory neuron numb to the effects of LTC4. And importantly for us, in vivo, when we run these mice through the acute itch flare model, these double knockout mice, we see we can abrogate this acute itch flare. So this is essentially the neuronal machinery that's required for this kind of LTC4 and acute itch flare mediated itch. So then we wanted to test, okay, we think that it's IgE, there's basophils, there's LCT4, clearly has an effect on the neuron. Is it the receptor for LTC4, which is called cis-LTR2 in the nervous system? And so this is a lot harder to do in a way because we actually don't have mice in which you can conditionally delete this receptor. But we can take another kind of technical approach is what we can actually do is either intrathecally or intracisternally into the CSF. This is the brain, the cortex and brainstem and the cerebellum. If we just inject into the CSF with siRNA, what we can do is actually disrupt the receptor cis-LTR2 by siRNA knockdown. So that's essentially what we did. And if you actually just put in control siRNA, and here we have PGP 9.5 staining. So you see this beautiful red staining of all the neurons. This is in the trigeminal ganglia. So this is actually similar to the dorsal root ganglia. And what we do is if you look in the neurons, you find that with control treatment of siRNA, you see some populations of neurons expressing cis-LTR2. And this is showing the merge here that these are indeed neurons. Now, if you inject the actual targeted siRNA, you can actually knock down expression of the cis-LTR2, and you really don't see much in the way of expression of this receptor, and this is quantified for you here on the right. But also importantly for us here, in terms of acute itch flares, with this siRNA knockdown delivered into the nervous system, we actually see a reduction in this acute itch flare. So what we think is, this is a summary slide, we've been working in recent years in understanding how chronic itch, we've been so focused on chronic itch because that's been so much of the buzz clinically. And we've done a lot of work at the neuroimmune interface to understand how lymphocytes and other populations may actually be major sources of cytokines that employ JAK-STAT signaling cytokine receptors to mediate chronic itch. But what I'm showing you here today is by looking at kind of high resolution clinical data on itch in patients, we're seeing these other phenotypes of itch, that there may be more than one kind of itch, even in diseases like atopic dermatitis, and the mechanisms may be highly divergent and very different. And may actually indicate there's a role for molecules like IgE, which have been rather mysterious, and then that this actually employs a very different kind of circuit beyond histamine, even though this is derived from a granulocyte like basophils, and through other receptors like canonical GPCR receptors that actually mediate acute itch. So I'd just like to end here and just say that we've just been focused on this disease rather tenaciously for a long time. It's a great disease to study, and I'm really happy for our patients that they've gotten so much better with these new therapies, and there's so much more to come. It's been scientifically a great disease to study in that we've been able to identify so many molecular and cellular mediators of various different processes across both the immune system as well as the nervous system. And as I've already highlighted, the future therapeutic landscape is quite rich, not just in atopic dermatitis, but a variety of other conditions, both in dermatology, allergy, and other disease entities as well. And lastly, I'd just like to thank the people that did the work, all the members of my lab. I showed work from Landon Etchen. Madison Mack was another graduate student that helped contribute to a lot of this work as well. And then recent work by Feng Wang, who's actually a dermatologist from China, and a fantastic postdoctoral fellow, all of our wonderful collaborators, both in academia as well as industry and other institutions, and our funding agencies. Most importantly, the NIH. The NIH has been absolutely critical to all the work that we do. And then last but not least, all of our patients who've really helped us to do a lot of translational work. And thanks to all of you for listening and inviting me.
Brian, this is Gallo. Thanks very much.
Thank you.
I have two questions, and one kind of more general for the clinical audience, and then maybe one a little bit picayune regarding the experimental method, if you don't mind. The general question is renal itch, and we're stuck with that so much. Can you illuminate anything about the pathophysiology of that? And then the specific question is the model of using MC903. It's kind of an odd thing. It's a vitamin D analog. It's going to do different things than just the standard tape stripping approach to permit ovalbumin penetration and sensitization. So I was curious about how you came to use MC903 plus ovalbumin and what you think the roles of that is in your results.
Yeah, no, thanks, Rich, and thanks for having me. The first thing, uremic pruritus is really, really fascinating. There have been a lot of theories about metabolites and all that, and it's no question these patients don't clear things very well, right? I have a theory about it. It's completely speculative, but because we haven't been focusing on that right now. We'd like to come to that at some point. But what's interesting about uremic pruritus is that the penetrance of itch is very clear cut, and there are drugs. Clinically, right now, Therapeutics had a great phase 2 trial with intravenous kappa opioid receptor agonists. So kappa opioid receptors actually act like they're suppressive, actually, of itch transmission. So they actually put the brakes. So when you stimulate them, they put the brakes on itch. They're totally different from the mu opioids. People get it confused and they worry that these are addictive. They're not. It's a very different opioid pathway. So I don't know how that works other than that kappa opioids probably suppress itch in some very broad way. But from the immune side, one of the things that we've always ignored in uremic itch is that we say, oh, it's some metabolite. It must be, I don't know, phosphate. I don't know, various things. But the one thing is that these patients are very, very immune perturbed, right? They die from sepsis. They're immunodeficient. And a lot of itch states are essentially immune imbalanced, pseudo immunodeficient states, is what we find clinically. And so the other thing they don't clear well at all is tryptase. So if you get a serum tryptase on them, it's very, very high. So I really wonder whether tryptase is a big factor in a lot of uremic itch. I'm not saying it has to be, but I want to just get at the idea that there may be some immune factor that's driving it. And I don't think we've put enough attention to that. So that's kind of my very speculative answer with your.
And just to follow up on that, I mean, it's for me in my small clinical practice at the VA, I've just had tremendous success with phototherapy, narrowband UVB, and all of these patients. I mean, it's inconvenient but tremendously effective.
Exactly.
Could that at all add to the understanding of why this may occur? Involved and it's photosensitive. I'm not sure.
Yeah, no, I think that the idea that I think also, to your point, a lot of the kind of the phototherapy, we've been kind of ignoring the fact that we think that that's largely a kind of an skin immunosuppressive regimen. But for some reason, when we talk about itch and uremic pruritus, we've been so focused on this kind of odd, like metabolite theory. I'm not totally against it, but I think we need to consider these immune pathways more. I'm not saying it's tryptase, but let's consider more, other processes. With regard to the MC903 model, the way I think of the mouse model there is that, my early days, I was very concerned about it. I think for me, the importance of the model is that it's a model, and does it align with the question that I'm asking in the human disease? And there are some things about the MC903 model that are fantastic. and does a really good job of recapitulating human atopic dermatitis. There's some things that it doesn't do so well of. And you know, and Rich, one of the criticisms, you know, that is really hard to deal with sometimes on NIH study sections would say, it's not a good model, or there's no good mouse model of atopic dermatitis. But that's true. There's no good mouse, you know, that's like a clinical, there's no good mouse model of any disease, because if it was a perfect model, it would be the human disease. But I think the most important thing is that there's an alignment of what the question you're trying to ask, you know, and for example, disadvantages in the model actually have worked to our advantage. So believe it or not, in this model, JAK inhibition is not so potent on the skin inflammation. So it's not so great if you actually match it up with what happens in humans. The anti-itch effect is profound in the mouse. And that led us to be able to probe the itch pathways in a way. So accidents sometimes are, accidental discrepancies are actually good. And the first time was we actually, my technician who didn't even care about the science told me, I remember the day, he said, I treated them with Rux and it didn't work. And I said, what do you mean? He's like, well, the ear thickness was only down like 10%, 15%. I was like, are they itching? Oh, he's like, oh yeah, no, they're not itching. I said, well, that's amazing. You know, and he said, well, I thought you needed everything to be down, you know? And so I think the important thing is that, this is my philosophy on it, is that you have to know what you're asking, and does it align with, and does it model what you're trying to ask in humans? And
no, I agree. I guess I just wanted to know if tape stripping is different than MC903 to permit barrier entry of the oval.
Yeah, I think it's different. And I think it's different in ways that may be advantageous. And I think that there is different ways that may not be. The other model that I'm kind of getting fond of is a house dust mite model, which, Galli's, former Galli Gaudenzio published recently. That's interesting too, because he's showing that house dust mite actually activates neurons to release neuropeptides, and it causes allergic itch. And I think that will bring new tools to bear in terms of alignment and axes that we want to look at in atopic dermatitis as well.
Yeah, you should try to filagra knockout too. That is so incredibly Th2 skewed that if you really want to exacerbate and kind of maybe even further model the human, but I'll shut up and let other people ask questions.
Yeah, no, thanks, Rich.
Hi, Brian. Anna Dinardo here. Thank you so much for your great presentation. I loved it. I also have two questions. One a little bit more clinical. It is about the JAK1 inhibitor. Yeah. Do we know which kind of side effect to expect from them, since how specific they are? And my second question is about if you investigate the role of mast cells in the IL-31 pathway.
Yeah, that's a very good question. So the clinical question with the JAK inhibitors, what's beautiful about the JAK inhibitors to me is that for us has been the biology of JAK inhibition really predicts not only the efficacy we see in patients, but also the adverse events. And one, I think, durable kind of truth in JAK inhibition in the clinic is that you generally don't want to inhibit JAK2 unless you're talking about myeloproliferative neoplasms, in which they're JAK2 driven. You have myeloproliferative disorders, myeloid cells. But in diseases like atopic dermatitis or a lot of other much more, quote, benign diseases, non-malignant diseases, that you don't want to hit JAK2. It's because otherwise you're going to have hematologic issues, platelet issues, maybe clotting issues. And that's what you want to stay away with. And I think that's where the black box labeling for tofacitinib or Xeljanz has come in, is that, that there's a little too much JAK2 activity. The JAK1 selective inhibition looks beautiful. It seems like you get more JAK1 selective. You actually get possibly better efficacy. But that's, I think, because you're able to drive JAK1 and leave JAK2, and maybe even JAK3 alone is a good thing in atopic dermatitis. This is a little bit speculative. For the itch, we think it's very JAK1 driven. So for us, we're fine with leaving JAK2 and JAK3 and tick alone. And if you see the trial data, it looks good. As you get more JAK1 selective, the efficacy gets better across the different ones. The safety signals for these drugs, the problem with these trials is they're 12, 16-week trials, right? So it's a very narrow window of safety. Have not been bad, okay? But the issues, but I don't want to be cavalier about JAK inhibitors. Xeljanz just got black box labels just in the last year, and it's been out for a long time. So I think we got to be really worried post-market and I'm not cavalier, I don't think that JAK1 selective inhibition is necessarily completely safe. I think it might be safer. So that's kind of my thoughts on the JAK signaling. Mast cells are very interesting. We are very obsessed with them because, and the mast cell obsession was originally what started this project that I presented. But what we have new data now that's really interesting, where if we actually stimulate mast cells, if we inject IL-33 into a mouse, and then 4 hours later and come back and inject histamine, the mice will itch like crazy in a way that they don't if you never injected the IL-33. And this is mast cell dependent. So it's 33 on mast cells. So, but we don't know what it is between the mast cell and the nerve that's conditioning the nerve to do this and get hyperexcitable. We don't know. So it could be 31. So I don't know. There's a lot of interesting stuff, whether it's 31 or maybe something else related to mast cells in this regard.
Thank you.
Thank you. We have a couple questions in the chat from Dr. Orm. So first question was, she said, I have patients who swear that ibuprofen helps with chronic idiopathic pruritus. Have you seen this?
Yeah.
And if so, is this related somehow to blocking leukotriene production?
Yeah, so it's interesting. No, I believe that. We actually published one in Jackie in Practice on a patient that technically met criteria for mast cell activation syndrome, but really probably didn't have it in the traditional sense. But we gave, the patient got better on ibuprofen. The allergist would say, don't give him ibuprofen, give him aspirin. And I do think there are patients in whom but I don't think we know who these people are. But I think a lot of these idiopathic itch patients do have mast cell activation. They don't have mast cell activation syndrome, but I think they have mast cell activation. A number of them actually have high normal or above normal tryptase. So nowhere near the tryptase level that would, they make my hematology colleagues balk and say, there's no way I'm bone marrowing or working them up. But they have high tryptase and they have a lot of itching. And so I think there are subsets. The question is, it's kind of trial by error. I don't know who those patients are. It's not everybody. And I think there's subsets. So I do believe that. And it might be whether it's prostaglandin or leukotriene, but in some of this kind of biolipid pathways that are being inhibited by it. So I think that's a real thing.
Thank you. I think you cut out for just a.
Oh, sorry. Can you hear me? Okay. Yeah, sorry. Can you hear me now? Sorry.
We can hear you.
Okay, sorry. Yeah, no, I do think it's a real thing. The bottom line is I think it's a real thing. I just think subsets of patients, a lot of patients with chronic idiopathic pruritus have mast cell activation, but depending on how the mast cells are activated, it may be responsive to ibuprofen or aspirin or not. And the thing that's, I think, interesting on mast cells is that they can be tickled in so many ways. And I think a lot of patients with allodynia, skin pain actually also have mast cell activation, but it's just been tickled in a way that causes more pain.
Do you ever, this is Dr. Orm, Sharice, hi. Do you ever trial things like ibuprofen? Like this is totally anecdotal from patients saying this to me, but I wonder if in patients who come in with chronic itch, if it's worth, instead of avoiding those things, trying a week of ibuprofen. And I have no idea how to even dose that, how I'd go about doing that.
Yeah. Yeah, allergists recommend aspirin, but we've done it. Yeah, we've done it. And the issue I think with idiopathic pruritus is you're really just throwing tomatoes to see what sticks. So I think as long as you're logically, systematically throwing tomatoes, I think that's a great thing, and the patients really appreciate it. Yeah. So I don't see anything wrong with that. And there are lots of patients, like I said, with elevated tryptase who have chronic pruritus, and we don't know why. And yeah. There's something weird about them. And I think there's lots of mast cell activation scenarios across many dermatologic disorders. It's just that I think we've been so focused on IgE, but there's so
Yeah.
much more.
And then I guess I have another totally unrelated question is, do you use a lot of aprepitant, and do you find it helpful? And what's your regimen? Because the literature is kind of all over the place about how long to give it, what dose. And I think I'm always not sure what I should do.
I do 80 milligrams daily of aprepitant, really safe and easy. That's not the challenge. The
Okay.
challenge is whether you're going to get it.
Right. So that's what
yeah.
I've been doing. That's what I've been doing is 80 milligrams. How long do you use it for then? Because there's different, 1 week, indefinitely,
Indefinitely. And,
okay.
And I've had patients respond, not everybody, obviously. And I honestly, I think it's really great for a lot of the patients who say that they have burning, stinging, and itching, like scalp pruritus. There's that sometimes facial dermatitis people who just, it burns. And I think a lot of that burning, I think, is this kind of neuropeptide, alternative mast cell activation. There's something, they're just getting very inflamed. They lose vasomotor tone. They have a lot of rosacea.
And then my final question, which is in the chat box, is how do you get JAKs covered? I have a hard time getting them covered for anything.
It's very hard. Yeah, I've had lots of different ways. I've had patients who have rheumatologists, and I say, hey, I know you probably have them in your sample closet. There's creative ways. Patients have been tenacious and just argued till the payers gave up. There's all different ways. But they've been very, very effective, broadly very effective so far. So we're hoping that trials come for these conditions in the future.
Thank you so much, Dr. Kim. Any last questions? All right, well, we really appreciated that fantastic talk and the great discussion it triggered. Thank you so much for coming.
Thanks, everybody. Have a great day.
Have a good day.